4, 5, 5, 6, 6, 7. Our patient has a nice neck. And let's get a, let me see, hold on. Shot. Yeah. Shot. 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 Let's get an AP quickly. So I'm going to just stay focused for a minute here. This is the hardest part of the surgery. There's one more part that's really hard too, but right now, so I'm a little too far to your side. Shot. That looks much better. Lateral. Go, 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 quick. Shot. Shot. Pretty collapsed disc here. Shot. 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 Give me an AP. Go. You're pulsing, right? That looks better. Still a little bit off to her side. Lateral, or shot first, then lateral. Lateral. Shot. Shot. Give me an AP. 2, 3, 4, 5, 6. That looks really good. Really good. So you can see the spinous process in the middle of the disc. You got to make sure the head's not rotated or neck's rotated. So this is a pretty collapsed disc, very degenerated. People ask, can this surgery work for degenerative disc? Yes. You can go back to a lateral, please. Actually, you know what? Since you're here, just stay here for a moment. We'll do a quick discogram. Coker. Get ready for a shot, and then go lateral shot. All right. Lateral. So. All right, very good. Just stay there on the lateral. And we're going to place the guide wire. Shot. Nice. How's blood pressure? Oh yeah, keep it down lower. I want it down around 100 to 110. I'd rather it be lower than higher at this point. All right. So I'm giving a little numbing medicine to the skin for 2 reasons. Number 1, it's got some epinephrine, and it's going to stop the little bleeders on the surface. And number 2, obviously for pain, which, you know, is negligible with her being under general anesthesia at this point. But still, there are reflex changes that occur as a result of pain. So I'm doing a 4mm incision. Let me know how's our blood pressure? Good? All right. Just wait a minute. Shot. Let's just make sure the guide wire hasn't moved. It hasn't. Good. I'll just apply a little pressure. Just wait a minute. So we're going to be doing 3 discs today. When I mean by doing 3 discs, it means operating on 3 discs. She has perfect. That's very good. Thank you. She has C45, C56, C67. She has a slippage at C7T1 shot. So she's got degenerative disc disease involving her entire cervical spine. And shot. You didn't register an image. And she's having horrible neck pain, headaches, and symptoms down her left arm as a result of this herniated disc and degenerated disc, okay? So her options would be a fusion, anterior cervical discectomy and fusion. And if you look at the disc that we're working on, this is the C5-6. So if you look at C2 up top, 2, and then count down 3, 4, 5, 6. This is the most collapsed degenerated disc of the 3 that we're working on. Then the C6-7 would be next, and then 4-5 is the least collapsed and degenerated. So this is a good case to demonstrate the that there's different degrees of disc degeneration. Let's get an AP. That this surgery works for. So people ask me, well, if the disc is collapsed, is that something you can still do surgery on? The answer is yes. Yeah, because it's not the collapsed disc that's the problem. It's the herniation and the inflammation going on in the back of the disc that's the problem. Lateral, that looks good. So we're just entering the disc space anteriorly. You can see the dilator is just to the left of midline as it's entered the disc. So if I were to pull it back a little bit to where it starts at the anterior longitudinal ligament, it would be right in the center of the spine. You don't have to be dead center to do the surgery properly, but you do need to be within a few millimeters, maybe 5 millimeters of the center shot. So now I'm advancing the dilator in to the C5-6 disc through the disc space. This is the transdiscal part. Look how it's opened up the disc space. There's actually in front of the dilator, which is to the right of the dilator, you can actually see the disc space is opened. It's distracted now. The bones are being spread apart. That's because we've got good muscle relaxation. It's allowing the spine to spread apart. Shot. So, shot. So we're all the way to the back, near the foramen, which is on the left side, the left foramen. So I want to cross to the opposite side. Let me show everybody what we're doing here, Sean. This is the tube that we're doing the entire surgery through. It's called the tubular retractor, and it's 4 millimeters. So the entire surgery will be done through this tiny little tube. That's why the incision is so small. You don't need to make a big incision to fit a tiny tube in. So the smaller your surgical field, the smaller the skin incision. And the less damage there is to the tissues underneath, as long as you don't like injure something vital. Now obviously, I make this surgery look easy, but this is a kind of surgery that it makes most neurosurgeons sweat, like they have hyperhidrosis, as my daughter says. Why? Obviously, it made me sweat the first time I saw it done. I couldn't believe what I was seeing. I'm sure our anesthesiologist is feeling similarly right now. If you haven't seen this type of surgery done before, and you're a surgeon that does spine surgery, it's pretty freaky. But the reality is I've done now 1,200 of these surgeries in the last 16 years, and I've gotten accustomed to doing them and knowing what to look for and when to look for it. Now this is a very scarred together disc, okay? It's very collapsed, degenerated, and scarred together. The bones are literally scarred together. Shot? And I can feel them. They don't want to give way. They don't want to allow the tube in. That's why it's important to have good muscle relaxation for the surgery. And I showed you guys last week when I did another one, similar shot, that the actual bones, it's a joint between two bones. That's what the disc is. It's a joint. And it actually improved the movement of those bones. If you remember, the movement was improved at the end of the surgery. All right, that's good enough. We're in good position. We're near the foramen. So I'm going to be treating her left arm symptoms as well as treating her neck pain and headaches. That's what we're expecting to go away. Just clean this off good so it doesn't. And how do I know? Well, obviously this is not our first Deuk laser disc repair surgery done. I've been doing them for 16 years, and we took some of our first patients, 66 of them, that had cervical done, and we looked at their outcomes, and we found that the ones that had headaches the headaches ended up going away. 95% of the headache went away. The cervicogenic headache from the neck. That doesn't mean migraines go away. It doesn't mean, brain tumor headaches go away. Headaches specifically caused by herniated discs. So why would a herniated disc cause a headache? The answer is simple, and it's overlooked by most doctors. Inflammation. Inflammation. The herniated disc causes inflammation. The inflammation gets onto the dura, or covering that goes up around the brain, and it causes a headache by irritating the dura, which is part of your meninges. It goes up into your skull and covers your brain. How do I know about this brain stuff? It might surprise you to know that I'm a brain surgeon. Yes, I am a brain surgeon, neurosurgeon. So I know a little bit about the brain and the spine. Neurosurgeons are trained to take care of brain and spine injuries. All right, so we are now inside. You're welcome to wear those, but you don't need to. Let me just grab. The red is not the laser, just so you know. That's just a targeting beam. The laser is off. It only goes on when I'm inside. All right, so I just grabbed now this is a very degenerated disc. Again, don't expect to see a nice, soft, fluffy disc. We're going to see pretty grungy area. All right, there it is. We're at the back of the disc. The blue stain is staining the nucleus pulposus. There's a piece of disc herniation right there. We call that a reverse herniation because it comes back into the disc space and then it goes out. So it goes the opposite direction of a typical herniated disc. There's another piece. So just the movement of the laser or the blast of the laser fiber actually frees up the fragments in the epidural space or subligamentous fragments of herniation, and it allows them to come out, to come back out. You're going to see some of that. Now right now it's very stiff. I'm having a hard time moving the tube. It's very typical at the beginning. And as I start to remove some of the scar tissue in here, I start to wiggle the tube a little bit. I can get it free. I'm going to come to the other side. So remember, we're going right to left to right, kind of switching back and forth. There's a piece of herniation that just went out. You all see that? Now there is going to be bone spur down here. That's bone spur right there. Okay? And our goal here is not to take all the bone spurs out. You can't judge a successful surgery by how much bone spur you take out. You judge a successful surgery by the patient's symptoms being gone. And that's how I've guided my treatments over the last 16, 17 years that I've been a neurosurgeon, is always based on the patient's symptoms. And, physical exam findings, if they have signs of nerve damage, then based on that as well. So, in the beginning, as I work on the severely degenerated disc at C5-6, there's going to be a lot of going back and forth, trying to get some movement so I can free up my tube and I can start removing some of the osteophytes and herniation that are causing this patient's symptoms, okay? The golden color stuff is calcium deposits. So this is calcified. There's another piece of herniation coming out. Again, you can see how the laser pulse of the laser is very helpful to, it's like when you, if you live in the South, right, and you have these mud wasps. Anybody know what mud wasps are? You don't know what a mud wasp is, doctor? All right, they make these little mud, like a mud ball on your house, up by the roof, on the walls. Luis, you know what I'm talking about. You get a pressure washer, and you blast it, and it starts to disintegrate with the pressure of the water jet. That's how you get rid of mud wasps in their houses. So the laser is similar to that. It has a heating element or heating component where it coagulates through heat and energy delivered directly to the tissue that you're trying to remove, but it also has a blasting component where you're actually a pressure wave, like a pressure washer, that blasts out pieces. Okay, this is a bone spur there. So we're slowly making progress. It gets better as we go along because you start to get more movement. You start seeing some of the movement, right, of the bones, just a little bit. We went from 0 movement to about 1 degree of movement. So it's not much. By the time we're done, we'll probably have about 2 degrees, maybe 3 if we're lucky, of movement. There's normally not much movement in the cervical spine at each disc, very little movement. As a matter of fact, there's only about 3 to 5 degrees of movement depending on what kind of movement you're talking about, whether it's rotation, flexion, extension, or lateral bending. And the discs that are below C2, which is what we're operating on now, these discs that are the most common to cause symptoms, they typically have about 5 degrees of flexion extension and about 3 degrees of rotation. But when you get to a situation where the disc is degenerated like this, then of course you don't have that normal movement. And the goal of this surgery is not to restore movement. That's not why we're doing surgery. The goal of our surgery is to eliminate the patient's neck pain that comes from the degenerated herniated disc, headaches, and arm symptoms. That's what the Deuk laser disc repair treats. Radicular symptoms, neck pain, and headaches. And even if the spinal cord is being compressed, we can also treat myelopathy. Okay, we can get rid of myelopathy, which is spinal cord compression, as long as it's from a soft disc herniation, not a really hard bone spur. Okay? So these bone spurs down here were all formed by inflammation over time, lots and lots. It's right at the foramen there. Any questions from our audience so far, Sean?
None yet.
Again, we've got about 1 degree of movement that we've created through the surgery. So not a whole lot. Nothing to write home about. There's another piece of herniation there. Again, bone spurs here. There's a very easy for the laser to get rid of bone spurs. So where do you normally work, doctor? Altamont Springs? Which one? I couldn't hear you. But you work at what, Biospine or where?
No, the spine in Altamont Spring.
Spine? What's the name of the company?
That's Dr.
Who?
Katzman.
Scott Katzman.
Yeah.
I know Scott. Uh-huh. I know Scott for 18 years now. Interesting guy. Well, you tell Dr. Katzman I said hello. How long have you been working there? Since 14. Wow. Yeah. All right. So there's not a whole lot of herniation to get rid of here. Because this disc is the most collapse and least amount of nuclear material, least amount of herniation of all three that we're fixing today. So we're just about done. I just want to look out the foramen, make sure I'm not leaving anything. Like I said, a little bone spur there, which we've managed to get rid of. And I'm going to look here. I want to get rid of some of that as well. That's more towards the midline. That could be headache causing. This is all scar tissue from inflammation, chronic inflammation. We're a bit overexposed. We need to bring the light down a little bit. That's better. That's too much. One click. One more. Really? Is that? I didn't see the brightness change. A little bit more. That's pretty good. All right, looking back here, not seeing much of anything left. I think we're good. All right. Off laser. All right, let's have the light on for a minute. Let's move this over. All right. Let's have the dilator. Oh, we could use that again, that wet one. You saved the wet one, right? Let's have the dilator. All right. So I'm going to take this tubular retractor out, and I've got my dilator in. Let's bring that in, the fluoro. I have to use an X-ray machine to navigate. You can't do any of this surgery without an X-ray machine. We call that X-ray machine a fluoro. It's short for fluoroscopy. Just be careful with that needle. And lots of doctors use fluoroscopy, especially pain management. It's lateral. Pain management doctors use fluoroscopy. Spine surgeons use fluoroscopy. Orthopedic surgeons use fluoroscopy. So it's a very popular technique in the operating room for treating joints, because joints are really spaces between bones. So the way we figure out what joint, where the joint is that we're trying to treat, is we use an X-ray image that looks at the bones. All right, so I'm going to take the dilator out, the tubular retractor out. Shot. So I'm just wiggling it out slowly. You got that? Shot. All right, so we're going to go down to 6-7, and then we'll work our way back up to 4-5 later. coming out. Okay, shot. All right, now I want to verify I'm in the middle. AP, Coker.
We have a question.
Not right now. I need a focus. Shot. Okay, I'm a little bit off to her side. I'm going to come back to my side. Shot. You always want to verify you're in the center before you start moving around lateral. Otherwise, things could get really bad very quick. Shot. So I got to make my way down. Shot. Usually there's enough play in the tissues you can do it. Shot. But honestly, this is probably the hardest maneuver, if not the second hardest. I said earlier, getting in first, go AP, is the hardest. But between starting the surgery and this is the hardest move. Perfect. I'm in the center. Lateral. Go. Malachi. Perfect. Shot. All right, let's get another AP just to verify. This is all about precision. This surgery is precision. And the fluoro machine you're looking at is a Siemens Arcadis Advantic, right? Flat plate. This is This is the very best X-ray machine in the world for intraoperative localization. All right, lateral. That's perfect. See how we're lined up with the spinous process right in the center? Perfect. Look at the endotracheal tube there. Deviated off to the left. All right, so I know I'm in good position. And this surgery, I've been told by neurosurgeons that have watched it, makes them cringe. Then again, you know, neurosurgeons do surgery that makes people cringe anyway, right? We take out brain tumors and clip aneurysms. So I frankly don't see what the big deal is. And I think it's just that they don't know how to do it. That bothers them. But once you learn how to do the surgery, it's not bad. It's actually, honestly, no different than clipping an aneurysm. And probably clipping an aneurysm is harder and more dangerous, far more dangerous. But once you know what you're doing with this procedure, yeah, you're right, I need to do a discogram, huh? Thank you for reminding me. Shot. Pipe cleaner. Is the discogram absolutely mandatory? No. It's very helpful when you're starting out. Shot. And you want to learn, like, what things are. Shot. 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 I'm just looking for the pipe cleaner. Shot. Shot. Thank you for pulling. That's helpful. Shot. It's almost there. Shot. Yeah, one more. Must be some junk in there. All right, good. The dye that I use stains the degenerated nuclear material blue. Shot. That's it. So it doesn't stain the bone. It doesn't stain the cartilage. It doesn't stain the annulus fibrosus. So what it doesn't stain is as important as what it does stain. And the staining of the nuclear material that's degenerated nucleus pulposus is all it stains. It doesn't stain normal nucleus pulposus. It only stains degenerated. It won't stain scar tissue either. So the white things we see could be normal nucleus pulposus, which this patient doesn't have any. It could be annulus fibrosis, which some is residual left there. It could be scar tissue. And it could be the end plates. So there's your little lesson on the anatomy. All right, dilator's in position. Perfect. Tubular retractor is ready to advance. We're going to advance through the anterior longitudinal ligament. Shot, want to watch the dilator, make sure it doesn't advance as the tubular retractor goes in. She's still relaxed, correct? Shot. Dilator advanced a little bit. Shot. And you just have to do a little bit at a time here, folks. There's no... Yeah, that's a better picture. You magnify it? Did you?
No,
Is that how it got bigger? Or you just pulled the shoulders? Probably just pulled the shoulder. My nurse woke up and pulled the shoulders. Not nurse, sorry. It's you. The nurse is sleeping. It's my technician, Jordan. High five, man. Oh, can't do that. We're good. So go ahead and get the fluoro back out. So we're in the, you can count the number of vertebrae. 2 at the top, 3, 4, 5, 6, 7. We are at the 6, 7 now. We're at the bottom of what we need to do. We're doing 4, 5, 5, 6, 6, 7 disc repairs. We've already done 5, 6. We're doing 6, 7 now, and then we'll go up to 4, 5. So the alternative surgery for this patient would be an anterior cervical discectomy and fusion, which would involve cleaning out 3 discs and drilling away osteophytes. It would involve putting in 3 spacers made out of plastic or cadaver bone or metal, and then fusing with a metal plate. Most surgeons would fuse. I'm not saying they would do all 3 discs, because for some reason spine surgeons don't like fixing everything that needs to be fixed at one time. They like to break it up into 2 or 3 surgeries. I think they make more money that way, that's for sure. I don't know what the motivation is, but I see people having multiple spine surgeries. They don't need multiple spine surgeries, they need one proper spine surgery the first time. And that seems to be a rampant problem around the country, around the world. I think I don't know why it is. I don't know if surgeons are really that greedy that they would make a patient go through 3 surgeries to fix 3 discs, or if they're just incompetent and they don't feel comfortable doing more than 1 disc at a time. But I see it all the time where patients are undertreated. All right, so we're at the back of the disc. I'm going to try to grab some of that out before I start blasting away with the laser. So that's been one of the problems I've seen over the years of doing spine surgery. For those of you wondering, how long have I been a neurosurgeon? I started 26 years ago in my residency at University of Florida in Gainesville. So from day one we're operating, and neurosurgery residency when I went through was 7 years, and I went to one of the top programs in the country. I don't mean top 10, I mean probably top 2, being University of Florida in Gainesville and Phoenix, Arizona, the Barrow Neurological Institute. Those are probably the top 2. Neurosurgery residencies typically don't follow the, in terms of quality, they don't follow the Ivy League standards that undergraduate does, and maybe some graduate programs do. The best neurosurgery training programs are the ones where you have the best faculty in their respective fields, subfields of neurosurgery. So that's how you determine the quality of neurosurgical training. Plus, when I trained, this is all herniated disc, by the way. I trained at a time when before the restrictions came for limiting hours that a resident can work. That's a huge herniation right there, huge. Oh, look at that thing. We're gonna pull that out. If I laser that, I'll be here all day. It'll be like chipping away at a boulder with a pickaxe or a Texas toothpick. Couldn't get it. I'm using my Grab-a-Laba. Oh no, it just doesn't want to come. All right, we're going to have to look at it again and see why it's not coming out. But when I trained, I was working in the hospital easily 110 hours a week, working, not sleeping. And some weeks I would put in 120 hours on your feet, awake, taking care of patients. It was brutal. Oh, I think no. Thought I had it. Tricksy little rabbit. He just doesn't want to come out. Oh well. So imagine working 110 hours a week on average. And that's because we had to take call, which means every third night you're living in the hospital, up all night, taking care of the sick patients who are, needing medical attention, surgeries, whatever. And that's what we do as residents. And it wasn't unique to me. Try again. It really was the standard for the last 50 years, really. It's highly abusive to the to the residents. Oh well, I'm just gonna have to keep wiggling at it. Doesn't want to come out. What's going on there? Fucking hell, well, say something. Don't just grunt. Say your bag is flipped. Anyway, that said, the American College or the ACGME of Graduate Medical Education laid down the law and basically said that training programs had to limit the number of hours worked by residents across the United States. And they restricted those hours to 80 hours a week maximum, but you could work 88 for continuity of patient care. So basically, a lot of neurosurgery programs just ignored this rule, and unfortunately, I didn't get the benefit of the rule until my senior year. It was about 2003 when we actually complied. There's a herniation right there, reverse. See that? That is a herniated disc wiggling out. We call it a reverse herniation. Deuk Spine Institute is the first in the world to describe a reverse herniation. We described it in our paper in 2012 in PubMed, National Library of Medicine, peer-reviewed, published. These little fragments that are coming back into the disc from that gap down there. See, this is outside the disc back here. That's in the epidural space. It's right up against the spinal cord. This disc right here, if I had to guess, is accounting for the majority of her headache so far. I think the last disc contributed less, and this disc more, because I'm seeing more. Look at this herniation just sitting here in the epidural space. Okay, so I'm going to have to zap that away as much as I can. And it's that herniation that's causing inflammation. And the inflammation is what causes the headaches and the neck pain. Okay, people don't understand that. And that's what needs to change, is our understanding of neck and back pain. Headaches from the neck. It's due to inflammation, not compression. Compression is not the cause. Inflammation is the cause. And all neurosurgeons want to do is decompress. They want to treat compression. That's what they've been taught to do, but it's wrong. And we need to change the way we think. We need to stop relying on, 100-year-old ideas that don't account for the true pathology, the true cause of disease. We need to be more understanding of what's causing our patients' symptoms. Okay? We got to get out of the dark ages when it comes to treating neck and back pain, and accept the fact that there are new technologies and ways of treating patients. They have to be embraced, and they have to be become more widespread use to help people. We're not in medicine for ourselves as doctors. We're in medicine to cure the ill and the sick, the weak, the frail, people suffering from diseases. And the problem is that everybody in medicine believes that neck pain is not curable, back pain is not curable, but they are with the right treatment. These are modern treatments, modern ideas. That's why we broadcast, so that people can learn the truth. You don't have to live in pain anymore. It can be cured. Pretty much all pain, except for fibromyalgia, is curable. You just have to understand the source, and you have to have a treatment that works. All right. So getting back to training, residency training, where you do your training in neurosurgery has a big impact on how good of a neurosurgeon you're going to be. And if you want to get a really good foundation, by the way, that's another piece of herniation. If you want to get a really good foundation of training, you have to stand by. You have to go for a good education. That's true for everything. College, high school, medical school. All educational institutions are not equal. By no means are they equal. The lower quality institutions don't want you to know that they're lower quality. But the reality is that they are. By the way, I told the patient I would review her MRI. She just had a new MRI done yesterday here at Deuk Spine, and talked to her about it. Your new MRI is definitely worse. Okay, I need to come up. And things appear to be more degenerated than anything, more collapsed than a year ago. So definitely she was progressing and getting worse. Feeling pretty good about this disc. We're not totally done yet, but we're getting there. There's definitely a herniation there. Right there.
We have a question.
Yeah, I'm sorry. I'll take the question.
That's okay. One of our viewers on Facebook is wondering, why don't you remove most or all of the bone spurs? What is the risk of leaving them?
So why don't I remove the bone spurs? Because they're there. What's going on with my irrigation? Is it still going? All right, yeah. All right, great question. So how can I best explain it? Every time you remove a bone spur, it's a risk. There's a risk associated with everything we do. Every cut, every blast, you want it to count, okay? So we don't just get rid of every bone spur. We don't want to get rid of the bone spurs that aren't causing symptoms. Not all bone spurs cause symptoms, right? Is that true or not? Have you ever seen somebody with swollen knuckles on their hands that have no pain or problems with their hands? Their hands work fine. Those are bone spurs. Have you ever seen anybody with a bone spur on their knee that has no symptoms? Yeah. Most people with arthritis of the joint have no symptoms from their arthritis. So what does that tell you? what it tells you is that most arthritis doesn't cause symptoms. Only some of it does. And it's the arthritis that causes symptoms that needs to be treated surgically. Nope. Okay? And by surgically means removing. Like we're talking about, removing the bone spur. So I'm not going to remove things no matter whether they're abnormal. Abnormal doesn't mean pathological. Pathological means something is abnormal and causing a disease or a problem for the patient. And we don't treat abnormal that's not pathological. Okay? Nobody wants to do that. No surgeon that I know of wants to do that. I don't want to do that. And the reason is simple. The more we remove, the more damage we do to the patient's body, because you're removing something that's there, and you only want to remove things that are causing problems for the patient. So really that's the philosophy in a nutshell as to why we don't take all the bone spurs out. We would also be here a lot longer. And, you know, being under anesthesia, every minute you're under anesthesia creates some risk for the patient. Okay? Anesthesia is not 100% benign and safe. We do anesthesia, we shut the brain down, we intubate the patient, they're on a ventilator, you know, but all those things have risk. The risk of pneumonia goes up, the risk of, you know, I don't know about oxygen toxicity, but I'm sure that could go up. The risk of hypothermia goes up and bleeding disorders goes up. What are some of the other risks of being under anesthesia longer that I'm missing? Our anesthesiologist is focused. So, but I can tell you, the longer you're under anesthesia, the higher risk for the patient. It's not good to be under anesthesia too long. So for me to sit here and try to pick away every single bone spur that this patient has would be more harmful to the patient and their well-being than just doing the ones that are symptomatic. This is a herniation in the foramen on the patient's right side, and it's pretty bad, so I can't ignore it. Now that, you know, that's something a little unexpected. I could see on the MRI they have a broad-based herniation at 6-7, but I didn't think it was this bad. But it's also calcified, that's why it's golden color. But we did it, we got rid of it. Okay. I need the light down just a little bit. One click. I think we're a little bit overexposed. I need my laser on. So every time you remove a bone spur, also you got to understand it causes some trauma to the bone underneath it, and you get some bleeding. That's what the bleeding is you're seeing. So it's insignificant amount of bleeding. Why is the laser off? It's an insignificant amount of bleeding, but any bleeding that can be avoided is always good. So that's another piece of herniation I'm floating out. That's called floating out. That's a technique I developed as well. Floating these reverse herniations out rather than trying to pick each one. Damn it, and I push the laser back in. There's a lot of scar tissue here. What is it, doctor? Everything okay? All right. I think we've done a phenomenal job here. I've gotten down, that's a bone spur I was just working on over there, by the way, here. Again, by the nerve over there in the corner. I'm very happy with the way things are looking. And I feel like we've cleaned it out. Good. So we're just about done with this one, and we're going to do one more, and then we'll be done with the surgery. I'm coming back to her symptomatic arm side. And a lot of that material coming out is just degenerated disc. So I hope you understand what I'm saying about the bone spurs. It's only the bad ones that need to be removed. And how do you know which ones are the bad ones? Aha. That's the magic. That's what's taken me years and years to figure out. Anyone who trains with me will probably learn which ones to take out and which ones to leave. This is still herniation here that needs to come out. This is not a surgery for surgeons that have not a great understanding of the anatomy, to say it nicely. This is a surgery for surgeons that have a very good understanding of surgery and anatomy of the spine. Many surgeons don't have this level of understanding, and I can tell you, I developed this level of understanding through microscopic surgery, which then led to endoscopic surgery. And many spine surgeons don't do microscopic surgery. Believe it or not. Hard to believe. It's shocking to me. Not knowing how to do microscopic surgery, but again, it comes back to the training we talked about earlier. It's quite simple. If you don't have the training for your 6 years of residency because your attending doesn't do microscopic surgery, then you are not going to know how to do microscopic surgery. It's that simple. So, unfortunately, there's a lot of residency training programs where microscopic surgery is not taught still to this day. And it requires a very special program with very special attendings. Attendings are the faculty that teach microscopic surgery. And of course, you can't do microscopic surgery without, it's a big herniation, by the way. It just snuck in there when we looked away. Big herniation. See, it's kind of wiggled around. Wonder if I can grab it out. That thing is huge. Very scarred and somewhat calcified. Of course, it's not been my lucky day with grabbing herniations out. The gods of herniations are laughing at me. Right, Luis? They just want to give me heartburn. But we can't leave that there. Oh, something happened. Still there. Why is my laser off? What is going on? Okay, well, you're going to have to tell Luis. Okay, you can't just keep hitting go. We need to have the laser people come look at it, right? Is that normal? Oh, yeah, it wants to come. Come on. Come on out. This is a headache-causing herniation right there. Look at the size of that thing. If I could just wiggle it free. That's one of the biggest pieces. I need it right about there. Look at. just won't come. So I have to go back and hack at it again. Louise, have them come. Look, it's under warranty. I want to know why it's doing that. Come on, get out of there. Come on. Let's see if I can grab it now. I don't know. Hard to say. Little bloody. Speaking of blood loss, this surgery typically loses 1 mil, 2 mils of blood loss at most. How's my irrigation? Good pressure? Feeling like the pressure is diminished. You got to stay on top of that. I don't want to have to stop what I'm doing. Huh? Yeah, now, once you pumped it. I rely on that pressure to help me vacate some of these lost souls. So I'm basically breaking this fragment of herniation up into little pieces until it gets light enough to float up. This is still a big guy or big girl. I don't want to be sexist. But I'm glad somebody can appreciate my sense of humor. Oh yeah, there's a piece of herniation right there. So don't stay in there, you little devil. A little bit overexposed still. Yeah, that's good. Thanks. Would like to get that last piece right there. That is a big beast. Just sticking its nose out in the foramen. Being a troublemaker.
So, yeah, you can, don't have to be
See how nice?
just put on the floor, normal towel. Yeah, well, please.
This is going to be all headache relief right here. This disc is a lot worse than I thought it was going to be, based on the MRI. You can never really tell. MRIs don't really give you a very good picture. It's only a static image of what's there, but the endoscope shows you everything. Because you're inside the disc in real time, seeing it all. You can see everything visually. An MRI, you're relying on magnetic waves to create an image that is really good technology, but not 100% accurate. Because there's a lot of volume, what's called, you got to pay attention. If it goes to standby, put it back on.
Okay, please.
Okay?
You can bring a normal towel.
Doesn't it say standby in front of your face? So when it goes to standby, put it on. We need to have it looked at.
Yes, sir. Yes, sir.
Yeah. Tell Ann to call the laser company now and let them know the machine is going to standby on its own for unknown reasons. Okay. Done here.
Lights on, please.
Scope off. Hello, McFly. All right, 2 down, 1 to go. get the fluoro in. Remember, you don't want acute bends. You'll break the fibers. You think it's a foot pedal issue?
So right there should be the index card with the number. Can you fill in or quick scan? Yep, please.
All right, this will be our last disc, and then we're going to be able to wake the patient up. Once I get in, then you can start getting her. You haven't given more muscle relaxer, right? All right, good. That's fine. What are we waiting for, folks? Go. We're waiting for your fluoro picture. What's the issue?
They're turning it onto the TV right now.
What?
They're turning it onto the TV right now.
Oh. So it's on the panel but not on the TV? Yeah, I would just, come on guys. What? Are we literally freshmen here? Come on guys. It's not our first rodeo. Yeah, that's fine. Pull the shoulders, please. Luis, you gotta, if you don't do it, I'm gonna get involved and you don't want me involved. Pull, you know, because I'm not gonna be nice about it. So take control of your team. All right. So there's 2 down. Shot. I need some of this stuff cleaned up. Okay? I need some of this cleaned up because there's contrast here. Take that. And the contrast is making the picture look weird. Shot. So 2, 3, 4, 5, 6, 7 done. Okay. Alrighty then. Shot. Let's get this out and moved up. Shot. Pretty close. Done. Shot. Good. I need a AP.
Right now?
Yeah, now. No, I need an AP tomorrow. What do you think? Of course I need an AP right now. Good, perfect. Back to a lateral. Nice job, by the way, on the fluoroteching. Just so you know. You're doing fantastic. Shot. Oh yeah, baby. I need an AP. What are you doing there? All right. Yeah, lateral. Yeah, tell her we need to let them know that it's, while it's on, it's flipping to standby on its own. Oh, you can relax. You look like you're on the United States bobsled team. Did you get a lateral? Is that it right there? All right. I need to go a little bit further. 2, 3, 4, 5. Shot. That's good. AP. Remember, you must shoot an AP before you enter the disc space. Cannot rely on a lateral. Could have moved to the side. That's it. Lateral. Then it would be catastrophic because you'll be going into the vertebral artery or some other soft tissue structure. If you ever start doing these, I would highly recommend you do not do multi-levels at first. Shot. You start with single levels. Shot. Okay. AP. Once I go through the ALL, I like to verify I haven't moved to the side. You can always correct if you've moved to the side. It looks perfect. And back to a lateral, please. this is our last disc. We're going to get in and we're going to do a discogram. Shot. 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 All right. Pipe cleaner. Just want to get the disc material out of the tube, out of the barrel. Shot. Perfect. We'll do our discogram and then we'll be on our merry way. Now of all three discs we're doing, this one here, shot, is the one that has, you can see the tear in the back. This one here is the most normal in terms of height, but it's also the most abnormal, shot, in terms of herniation. It's got a pretty good size herniation back there. And the last one we did, 6-7, had a lot of herniated fragments. Remember how many pieces we took out? Big ones, small ones. They were just, it just shows you the injury to the disc is more extensive. And that's a degenerated disc, by the way. Okay? So for anyone asking, does Deuk laser disc repair surgery, what you're watching right now, does it fix degenerated disc? The answer is yes. It definitely fixes degenerated disc. And why is that? It's because I'm not repairing the disc height. I'm not restoring the nucleus back to what it used to be when the patient was 17. I'm merely removing the fragments of herniation, but also importantly, the most important thing I'm doing is debriding the annular tear. Shot? All right, so the dilator went forward a little bit there. So you have to be just careful it doesn't keep going. Otherwise you'll end up with some problems. Shot. And for those of you wondering, how hard am I hitting this thing, shot? It's not hard, okay? It's not hard, shot. It's really delicate. Imagine if you had a goldfish as a pet and that goldfish was misbehaving. I got Luis to laugh. Thank God. Somebody's laughing. All right. You know, we do try to make it humorous. Try is the key word. Maybe we don't make everybody laugh, but that's okay. I know the people at PETA are not laughing. Right, Luis?
People what? I'm sorry.
At PETA.
PETA?
People for the Ethical Treatment of Animals.
Oh.
They're not laughing at my goldfish joke, but oh well. If you don't ask questions, I tell really bad jokes. That's the way it works. So if you're watching this live stream, and by the way, Deuk Spine Institute broadcasts all of our spine surgery live over the internet for free to educate the public about contemporary issues in spine care. We take questions during the surgery and try to answer them. We don't do politics, so don't bother. We talk about spine surgery, maybe something about racing, because Deuk Spine Institute has a racing team. Oh yeah. We have a top driver in the world. Okay, there's the herniations down there, little pieces, and we're going to get started. Ooh, there's a nice reverse herniation right there. That's a biggie. Remember what I told you, of all the discs we're fixing, this one is like a softer, more normalish looking disc, not as advanced with the degeneration as the ones we've been looking at. We have about 10 minutes, doctor, for anesthesia, if you want to start getting her closer to being awake. We'll be done in 10 minutes. 15 max. Look at that reverse herniation. It just wiggled out. Beautiful. Please. These are all fragments of herniation. There's just so many of them. And they're just going to they're going to want to come out. Like there's another one that just shot out. If you go back and you play this video in slow-mo, you'll see through that tear down there, the annular tear, there's a lot of little pieces just shooting out. But they move so quickly, they're like a, whoa, look at that big herniation that just wiggled out. Oh, ho, 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 ho. Mama. Oh, yeah. You all saw that came from the depths, from the abyss. That abyss is the epidural space, by the way, beyond the borders of the vertebral body. Ooh, let's show our audience. Turn the light on.
Lights please. Lights on.
This is a decent one.
You wanna?
This is a decent fragment. You all see that, Sean? Give me the overhead, eye in the sky. Huh? You're kidding me. Oh, well, whatever. Here, take this. Sorry if you didn't get to see it. We'll show it to you later, maybe. That will be under the director's cut. The extras. Sean stepped out. All right. So, I'll just keep talking then. There's the tear in the back of the disc. It's huge. There's another herniation that just shot out of there. And most of these I'll just float them up because they're small. It takes too much time to put the grabber in. And it's inefficient because the grabber a lot of times can't grab them. They wiggle around the grabber. So the best way to remove them is most of the time is just with the hydrostatic pressure. My God, that's a huge piece of herniation right there. This is a lot worse here than it looked like on the MRI. Don't rely on your MRI, folks. One of the things that everyone should understand, if you're having neck or back pain, it's curable. You just have to find the right place to get it fixed. There aren't many. There are only a few in the world. But more importantly, the MRIs many times miss this stuff. You see that herniation come out? Just hit rewind, you'll see it. It came out of the depths. Oh, yeah. They're just popping out left and right now. And again, what does it is the unique feature of this laser. It's a pressure blast. And anytime you create an energy wave through water, it creates a cavitation, which is it's basically a pressure wave shaped like a dumbbell, and it's called the cavitation effect, and it basically blasts whatever's in front of it. So I talked about this many times in the past through videos, but the laser has two ways of working. One, through thermal energy delivered to the tissue in the form of laser energy, electromagnetic radiation. The other is a wave, like a burst, like a power washer. A shock wave, essentially. A shock wave. Just about done. Probably 8 minutes left, if I had to guess. Pretty messy over here still. I'm going to flip this laser and scope around and aim towards her right. Good. Thanks for letting me know. There's a big herniation there. I don't know if you all can see that. Just wedged in there. Just sitting in there. We've talked about the similarities here between what we do, repairing the annular tear, and the movie Pacific Rim, right? With the Jaegers and the kaiju. The kaiju, of course, being these herniations, and the Jaeger being our laser and scope fighting the kaijus. Anybody know what I'm talking about, or Sean?
I know what you're talking about.
Huh?
I know what you're talking about.
All right, good. As long as you do, we're good. Oh, look at that. So this is a blowout, folks. That's part of a blowout right there. That's a piece that was sitting right on top of the spinal cord, right on top of the posterior ligament. It looks like it doesn't want to come out easy, so I'm going to have to try to grab it out. Any questions?
None currently.
Cool. So the view you're seeing, everyone, is an endoscopic view. You're looking with me through the endoscope and seeing the anatomy of the back of the disc endoscopically. This is not a surgery you're going to be able to find being done near where you live. There's only a few surgeons in the world that know how to do endoscopic spine surgery, true endoscopic spine surgery. There's a lot of fakers out there. They say they do it. By the way, those white fibers are the posterior longitudinal ligament fibers. Okay? And they look pristine. I'm not going to mess with them right there because they're intact. A lot of disc herniations are subligamentous, meaning they're on my side or our side, the disc side of the posterior longitudinal ligament. Okay, and then the posterior ligament ends right there. And then you get basically dura right here. And there's a little bit of herniation there underneath the nerve root. And that's what I'm working on. Just peeling these little flecks of herniation off of the root. That foramen looks good. It's a little bit of degenerated cartilage. It's loose and moving around. I don't like that. It may move into the foramen when we're, oh, there's some pieces from the foramen right there. Beautiful. I think she's going to do fantastic. So what do I expect? When she wakes up, I expect, hopefully, we won't give her nausea, vomiting, but you never know. Sometimes we do our best and they still get nausea, vomiting. But most people don't have nausea, vomiting after surgery. But some people are very sensitive to anesthesia and they may have it, okay? But that's not, I'm just mentioning that because this particular patient has had a history of post-operative nausea, vomiting. And we may see that. We may not. And what we expect to see is that I expect her headaches to be gone. I expect her arm symptoms to be gone right away. And I expect her neck pain that she came here with to be gone. Now, will she have neck pain from the surgery? Of course. We're back here zapping away things. So she'll have some pain at the base of her neck. It'll be discomfort. And it'll last a few days maybe. And that's just from the surgery. Okay, there's the foramen, by the way. Beautiful. Almost done. About a minute, maybe 2 minutes left. Doctor?
Yes.
It's about 2 minutes and we'll be done. Now, so I expect the headache she wanted gone. That was her number one thing. I want those gone. The number 2 was her arm symptoms. Number 3 was her neck pain. And I expect all 3 of those to be gone. I expect she'll have some discomfort at the base of her neck as a result of the surgery. The people that have this surgery as opposed to an anterior cervical discectomy infusion, ACDF patients are going to have swallowing problems from the metal plate that was just put in their neck. They're going to have hoarseness that's bad. Our patient will have a little bit from the tube, her endotracheal tube. Oh, I gotta go see over there. But she shouldn't have much hoarseness at all. So we're going to check her out, hopefully, if she allows us, in the recovery area. Oh, come on, get out. Stand by. Let me grab that guy. And we'll be done in about a minute. Why, guys? Why loud noises? Really? I'm going to put an amplifier in your ear. So you got to hear it really loud. Just be more aware. We don't like loud noises in the operating room. All right, this should be our last look out the foramen. And we're pretty much done.
Stand by. Mobile, please. Lights off, please.
I'm going to show you folks, we just fixed 3 discs. We didn't fuse. We didn't put any biological material like cadaver bone or BMP or any of those materials. We didn't put cages. We didn't put a metal plate. We didn't put anything. We're not leaving anything foreign in her body, okay, except for a little medicine, which goes away.
Yeah.
Okay. Let me have the dilator. How long did the surgery take, skin to skin? When did we cut? An hour and 22 minutes for 3 levels. Okay. If this was a fusion, most spine surgeons would be taking about probably 3 or 4 hours to do the surgery. We finished it in an hour and 20 minutes, Luis. And guess what? Our patient's going to go home in an hour. Home, not the hospital. By the way, we're not at the hospital. We're at Deuk Spine Institute. So we don't have COVID here. And in 16 years of doing these surgeries, I've had 0 complications. Not a single complication. Not a single perioperative complication. That means in the operating room, and that means afterwards. Our recurrent disc herniation rate is about 1%, maybe a little bit higher, 1.2%. That means patients who had a herniation, had the surgery, did great, and then re-herniated sometime afterwards because most of the time they do something they're not supposed to. They lift something heavy. They do too much physical activity too soon, and they don't follow the restrictions. But for some patients, they don't even know what they did. Maybe the way they slept or something, who knows. But the recurrent disc herniation rate is about 1%. I'm going to show you the incision on the neck, okay? Can you guys see this, Sean?
Yes, we can.
So the patient's chin is here, their face is here, the chest is here. This is the right side of the neck, and look at that, 4 millimeter incision. Okay? There's no hematoma, the neck is supple. Our anesthesiologist did a phenomenal job. My team did a great job, except for, just kidding. Everybody did a great job. All right, so go ahead and write your questions down, and I'll come answer them for you in our post-op interview with Dr. Deuk Majan, the surgeon, the founder, the funny guy, the comedian. Huh? Yep. All right, I'm going to call the EBO 1 mil. DLDR, this is a right approach. C45, 5, 6, 6, 7. All right, very good, everybody. I'll see you all soon. And I'm coming over to the conference room to answer questions, so type them up. Yeah, I'm going to take it off.
All right, everyone, welcome to the post-op Q&A. We're still waiting for Dr. Deuk to join us in the room here. If you look on the screen, we're currently taking a look at this patient's MRI report that was done prior to their surgery. If you read closely, you can see the 3 levels we just operated on. There were disc herniations and nerve impingement identified at all 3 levels. This was confirmed by a physical evaluation and an examination by several of our physicians. So hopefully when we follow up with this patient post-op for their testimonial, they will report total symptom relief. That is what we are expecting for them. We'll be bringing up the face cam shortly, and Dr. Deuk will talk to you a little bit about the procedure you just watched and answer any of your remaining questions. Go ahead and type up any questions you still have in the chat now.
All right. Hello. Welcome. It's February 23rd, 2021. I'm Dr. Ara Deuk-Majan, surgeon, CEO, and founder. We just finished a 3-level Deuk laser disc repair. Our patient presented to us with basically degenerated discs, which are collapsed discs from injury. And the injuries are always the same, folks. It's basically trauma to the disc and that affects the outer part of the disc. I need a snap-on mic. We need to get one. And basically that outer part of the disc is called the annulus fibrosus. Can you hold this for me? So this is what a disc looks like, kind of like a kidney bean. It's got a jelly center called the nucleus. It's got an outer rim that's about that thick. It wraps all the way around the nucleus and creates a border that holds the jelly in place. And the the problems are always the same. No matter what happens to your disc, if it's not perfectly normal, it starts with a tear in the back of the disc that lets some of the jelly seep out. That's the red stuff. Forget about this tube. All right, so the jelly basically comes out through a tear and then it sticks out here. And everyone knows that's called a herniation, a herniated disc. This is the herniation itself, but there's two parts to the herniation. There's the part that's really outside the walls of the disc, and there's the part that's stuck inside the wall. And what I've discovered, and my contribution to understanding back and neck pain, is that it's the part that's stuck inside the tear, called the interposed nucleus. That's the source of inflammation in the outer annulus that causes the chronic back and neck pain that people suffer with when they have a herniated disc as the cause of the pain. So the Deuk laser disc repair is the first surgery in the world to actually go and debride that tear, clean it up, get rid of the interposed herniation as well as the mushroom cap, the part that's outside called the extruded disc. So I fixed both with the Deuk laser disc repair. Most surgeons only target this part out here. They don't target all spine surgeons only target the mushroom cap. They don't target the stalk that's embedded in the annular tear. And that's what distinguishes the Deuk laser disc repair, the procedure I created here at Deuk Spine Institute 16 years ago and we've published. That's what distinguishes our surgery from every other spine surgery on a disc that doesn't do an annular debridement. We're the first to describe it in 2012 in a journal called Surgical Neurology International. It's peer-reviewed and published. It's indexed in the PubMed in the National Library of Medicine. It's the best evidence in the world that the procedure actually works and it cures pain. So that's really what we do. We go in there and we clean up the annular tear, the one that's causing pain. It's always in the back of the disc, not the front, not the sides. And I use an endoscope and a laser to do that. And if you rewind, you go back and see exactly what happened. So this patient with 3 discs, she has a combination of herniated discs that some of them have happened so long ago they've kind of collapsed over time. It's kind of like getting a hole punched in your tire. If the hole punch just happened now with a nail, it'll probably be a few hours or a few days before the tire sinks all the way down. So think about the really degenerated discs as being ones that were injured many years ago and they started collapsing many years ago. Now, they may not have been symptomatic many years ago. The symptoms may only have started recently. And so that really has to do with the individual patient's condition. We see patients with really badly degenerated discs that don't have any symptoms or complaints at all. They're perfectly normal. And so just having a degenerated disc or having a herniated disc doesn't mean you need treatment. Earlier we had a question about bone spurs and why don't you get rid of all the bone spurs? Because when you remove a bone spur, you're actually doing some damage to the bone that's there that is left. It bleeds a little bit. It's going to be inflamed and irritated. And so we don't want to remove bone spurs that aren't causing problems. And bone spurs rarely cause pain in the neck. Now, a bone spur in your shoulder is a different story. A bone spur in your hip, it may be a different story. But the pain comes from inflammation, and bone spurs don't cause inflammation. They rarely do. They can push on your spinal cord and cause spinal cord damage. In that case, they need to be removed. But I can tell you right now, about 98% of my patients don't have significant bone spurs causing symptoms. They have tiny bone spurs that are easy to remove during the disc repair. All right, what's our first question?
So our question comes from a viewer on Facebook who is wondering, what is your follow-up post-operative routine like? How often do you check in on patients, and do you do long-term follow-ups to confirm that the surgery lasts for a long time?
So great question. So what's our post-operative follow-up program like? Well, we like to see our patients back the next day in clinic and check on them. If they can't make it, that's fine. We want to at least hear from them and make sure they're not having any issues. And then we like to see them back a week later, and then 6 weeks later. So whether we see them in the office or we see them virtually over the computer, the ideal follow-up is 1 day, 6 days, and 6 weeks. After that, we don't really require any follow-up or need any follow-up unless the patients are having a problem. Some patients do develop issues, not from the surgery itself, but they may have pain, for example, in the facet joints, or they may have pain in the sacroiliac joint, or the piriformis muscle, or their paraspinous muscles. So when we fix someone's back pain source by repairing the disc itself, we eliminate the disc source of pain, but we're not treating the muscles with the surgery. We're not treating the facet joints usually with the surgery. We're not treating other joints and tissues around the disc that do cause pain. So about 25% of our patients do end up having some aches and pains from other joints and other issues. A lot of times wearing the collar after surgery causes muscle spasms and muscle pain. And that's the trade-off for wearing the collar. By wearing the collar, the patient is basically helping stabilize their spine while the disc that we just repaired will heal itself. It takes the disc about a year to fully heal. And in the first 6 weeks, it's very susceptible to being re-injured by the patient doing something they shouldn't do. So by putting a collar or a brace on, it kind of restricts the movement, and it's a reminder to the patient to take it easy. So we usually have patients wear a brace for 6 weeks to keep them taking it easy and not doing something that could re-injure those discs that I just fixed. But wearing the collar definitely will cause muscle aches and muscle spasms. And we see that all the time. And it's kind of like robbing Peter to pay Paul. But the muscle aches always go away when the patient gets out of the brace and does their physical therapy routine that we always recommend for every patient. So patients that follow our physical therapy recommendations and see our therapist, Dr. Schrumpf or her team, they end up having those muscle aches stretched and treated through stretching exercises, massage, and other methods of physical therapy. So what I'm getting at is, if the patients do what they're told and they wear their braces after the laser surgery for 6 weeks, they are going to have aches and pains from other areas. And that's why we have physical therapy for them to help address those aches and pains. But I'd rather have them have aches and pains from their muscles and facet joints, which are easy to fix, than from a reherniated disc where they're going to have another surgery. So it's all part of the post-op treatment. And as far as long-term outcomes, yes, we do track long-term outcomes. But typically what we have to do is contact the patients years later. We go to the charts. We find people who have had the surgery. We call them. We ask them how they're doing, how much of the pain is still gone, and then we document that. We've already done that long-term outcome study for the lumbar. And our patients that have had the lower back Deuk laser disc repair, we looked at minimum of 5 years of follow-up. So that means they had their surgery over 5 years ago when we started looking at the charts and started the study. And we found that the patients average 6 years of follow-up, they had 95% elimination still of their back pain and their leg symptoms. So 95% elimination of the back pain they came to us with, 95% elimination of their leg symptoms. That's pretty darn good. There's no surgery in the world that gives better long-term outcome results than the Deuk laser disc repair. We're in the process of publishing that in a journal. It's already been published once at a meeting at the, I think, of the American Association of Neurological Surgeons, or the one of the meetings. It was peer-reviewed and published. So it should be in a journal soon. Okay, great question. Any more questions? That was our last question. We have another 3-level Deuk laser disc repair, cervical, coming up. She has neck pain, headaches, and arm symptoms. It's on the right side again that we're going to be going in to treat mostly left arm symptoms. Now, she does have a thick neck, so I've already talked to her about the possibility I may not be able to get all 3 discs done. It depends on the safety of being able to do it based on her neck once she's under anesthesia.